Bismillahirrahmanirrahim. This is a very interesting, rare case in my life. This is my first case in my life. I'm 40 years in practice. Dr. Mirvat, Anna. This is a 12-year-old female child. I saw her when she was 7 years old, and she had what looked to me as atrial tachycardia and was not sustained. It was paroxysmal recurrent atrial tachycardia. We gave her medication, and she left. Was not seen for follow-up, and then she had a small PFO, and she underwent closure for this. We didn't know why, but that was the case. After that, the tachycardia was running in and out. Dr. Iman will give us full history about the child.
A 12-year child started to have tachycardia since 2022. Long RB tachycardia was in Indral and Ritmonorm, and still incessant tachycardia. So we decided to go for.
Her echo was?
Echo was normal, yes. Just mild mitral
we'll show you the
collapse.
ECG. Ali, place the ECG as you can concentrate on her ECG. This is the ECG running in the clinic, and also her Holter was seen. We thought this is long RP tachycardia, and by exclusion, this is atrial tachycardia. However, we see that the tachycardia, the atrium, is not, it ends by A, not by V, and followed by sinus beat with prolonged PR interval. So this is what came to my mind. This is atrial tachycardia, paroxysmal recurrent, and that was since she was 7 years old. Echo Iman is normal, apart from yes. So we decided to give her 3D ablation using our team, intelligent team. So when we started, Dr. John is that we could not take it as is, because the termination of the tachycardia by A. Oh, this is blocked atrial premature beat or tachycardia beat. Yeah.
Tachycardia.
Then
شيل الأصفر.
Then we have VV changes preceding AA
Okay.
changes.
Yeah. So the tachycardia was running like this. Dr. John with us and Muhammad Saeed, and لا خش على tachycardia, and we had this. They had this feeling. It was not me. They had that feeling that this is AVRT. AVRT. And it terminates always in an A. So we started to do maneuvers and to go in depth in the mechanism of the tachycardia. Okay, they noticed this V interval is preceding is driving the AA interval. Yes, as we can see here, that change the V causes change in the A. So the A is linked to the V. Also, we made parahesian pacing.
Yes.
Parahesian pacing was exact same. So here, تعالى علي هنا, تعالى هنا. Parahesian pacing was exactly the same number. So we said this is most probably an accessory pathway. Okay, this is not what we used to see in children with fast heart rate, but the tachycardia was slow, and that was since I saw her when she was 7 years old. Maybe it was before, maybe it was since birth, we don't know. So the parahesian pacing, the VA time was the same with the narrow his capture and without his capture.
Narrow,
go back.
Wide.
Yeah, and the same number of VA time. هات بقى كمان. This confirmed the same. So when we started, we said we'll do the map for what did we did entrain. We did entrain. We did entrain the tachycardia, and you see this V pacing entrained the tachycardia, show us that it is entrained with the same sequence. And this is the VV interval and the same. And when we stopped V pacing, هات بقى اللي بعدها. The tachycardia stopped and came again. Okay, we were mapping in the beginning as if we had an atrial tachycardia. Because I'm the boss, I told them this is atrial tachycardia. So they had to map for atrial tachycardia, and we found that it is in the right atrium. Very good. We were looking for an early A, and here. Yeah, but this is the end. This is the end.
No,
so
this is where we ablate.
I know. لا أنا مش عايز أقول end. When we started, we found that this is the hot area, this is the his, this is the right anterolateral area. We were looking for the A because we were thinking this is an atrium. But when we made the maneuvers and confirmed that we have probably a concealed right anterolateral access pathway, we started to look for the V. And this hot area, when we had the V signal and small a, very close, very short V time, we ablated here. We tried to ablate with only atrial segment, but we could not terminate. We gave isoprenaline, the tachycardia was incessant, and it helped us to map. When we came here to the area where there is very short VA time, big V, small a, in the anterolateral region, we could terminate it. And the surprise is the V pacing, and VA dissociation. This is confirmation. Say whatever you want, finish the story. If you have a VA dissociation, this is because this team is better than me.
No.
Yeah, كبر signal دي, كبر دي. So this is, طبعا of course Pruka, Rosasi is sitting on the Pruka, Rahma and Myrna are sitting on the 3D. We have all brains for this case to be successful. This is the V, this is the A, which we saw it in the hot area, but we got V. This is where it was ablated. Show us back كده.
Before ablation,
we
stop the
bumped.
retrograde.
It bumped here, and ablation was done. Yes, ablation. It came again. Came again. Okay, VA time. أهو. Yes. هنا ablation started here. Go. Terminated immediately. And this is the AV. Of course, she has AV from exhaustion of the AV node. Yes. This is the tachycardia stop. We'll show you confirmation of what we said. Pace ventricle. Now this is live. You see, VA dissociation. We showed you before that we had VA conduction during the tachycardia with the entrainment of the tachycardia. So this is a very, very rare case of a concealed right anterolateral access pathway behaving as if it is a long RP tachycardia, as atrial tachycardia, but because we have about maybe 30 brains here, so we could reach diagnosis. Thank you.